These are very troubling times indeed. Insecurity rocking the fabric of stability of the international order, wobbling global economy, throwing governments and peoples of the world into money panic. Now, the impact of variations in weather and climate is also dawning on us, and in parts of the world, it's extreme heat, causing heat waves, fire, and other kinds of ill health. In other parts of the world, it's extreme cold weather liable to trigger more health-related conditions. Now, for us in the tropical temperate, especially in Nigeria, the raining seasons are, trigger for some non-communicable diseases, and we're talking about ailments like malaria. The rains come between April and October and peak between July and August. Now, research works indicate that many people are afflicted, with malaria during the raining season. And we're also told that the peak of the raining season is also times when children come down with severe bouts or cases of malaria. Now, the wet season triggers fertile grounds for breeding of mosquitoes, which of course we know is the vector, of course, that carries the parasite, that's Plasmodium falciparum. Now, stagnant waters, dirty gutters, and environment are very comfortable habitats for malaria vectors, that's mosquitoes, to breed. Research has revealed that Nigeria accounts for more than 30% of the total burden of malaria in Africa, and that 97% of our population is at risk of infection, in which case 51 million cases recorded annually, with more than 200 deaths alone from malaria complications. And of course, we are also told that malaria is the cause of 30% of mortality among children under the ages of 5. And children under 5 are, of course, the most vulnerable groups affected by this disease, and they account for 67% of all malaria deaths worldwide. And that's, of course, what the WHO Regional Director for Africa has told us. Nigeria has made significant progress in rolling back malaria scourge, of course, since the millennium, especially during the period of the Millennium Development Goals, and even now when the Sustainable Development Goals are being implemented. But there are still wide gaps in the area of prevention. And we know that the journey by National Malaria Control Program to achieve 80% coverage of long-lasting impregnated mosquito nets, it has been long but protracted. In 2021, a breakthrough in the research for malaria vaccine was made, and that's the RTS, or Malaricwix. I hope I got that correct. It's simply a vaccine that was introduced by the WHO as the magic drug. However, because of availability issues, most children, have not been reached. In 2012, let me just take you a bit back. The World Health Organization recommended the use of seasonal malaria chemoprevention for children in this vulnerable group. WHO believes that it is SMC, that's the seasonal malaria chemoprevention, is a protective strategy that can reduce malaria morbidity and mortality, especially among children from ages 3 to 5, I guess. Now, WHO says SMC is a priority for malaria eradication. So how effective has this been? And on Late Edition this week, we engage renowned public health experts on all we need to know about this magic prevention drug, which is called seasonal malaria chemotherapy. I am Claire Delabo Abdulrazak. Thank you for joining me. So let me quickly introduce my guest. Dr. Shakarao Emmanuel is the national focal person on seasonal malaria chemoprevention, National Malaria Elimination Program, Federal Ministry of Health. He's a medical doctor, trained epidemiologist, and has over 10 years working experience in public health. He has been in the malaria space at the National Malaria Program for many years, and it is in this capacity that he has been greatly involved in implementing malaria preventions and providing policy direction to states. He's also instrumental in providing support for implementing partners with expertise in malaria case management and drug-based prevention. He coordinated reviews of several case management strategic documents, including national guidelines for diagnosis and treatment of malaria. He participated in several local international trainings, workshops, and seminars on malaria programming. He's a fellow of Nigerian Field Epidemiology Laboratory Training Program with certification from U.S. Centers for Disease Control. Now, my next guest is a pharmacist, and he's Musa Al-Hasan Mohammed. He's Director, Health and Human Services Secretariat, Federal Capital Territory Public Health Department. And since 2008, he has a wide experience in public health management and has received numerous trainings on public health administration and management. He has coordinated several units, head disease control divisions, among others. Pharmacist Al-Hasan Mohammed has also been the program manager, FCT Malaria Elimination, since 2017 to date. He was program manager FCT HIV and AIDS from 2009 to 2011. He pioneered and coordinated FCT Procurement Supply Management (PSM) from between 2011 and 2015. He was pioneer coordinator FCT Logistics Management Coordination Unit (LMCU) between 2015 and 2017. Gentlemen, I'd like to welcome you to Late Edition this week. Thank you.
Yeah, thank you so much.
All right, so let's begin. Malaria is not a new disease, and for us here in this part of the world, it's an issue that we have been dealing with. I mean, since I was born, I've been hearing about malaria and all that. Why is it still an issue, a burden for us? Let me start with Dr. Shakarao. Why is malaria still a burden for us?
All right, thank you very much for the question. So malaria, like we know, is still a burden for us because it's one of the leading causes of death, especially among children under 5. And so it's a burden because oftentimes the general populace do not know the appropriate steps or interventions to take in order to prevent malaria. Like you have rightly mentioned in your introduction, one of the problems we're battling with is the need to ensure proper preventive practices are put in place in order to, stall the effect of malaria cases in our environment. For example, you mentioned the need to ensure that our environments are clean, stagnant waters are not there, in order to breed mosquitoes, which usually carries the parasites that gives this malaria infection. And also, there are various interventions in place that can easily prevent persons from coming down with malaria cases. But oftentimes, these are not readily accessed or readily used by the general populace, even when they are made available. For example, when we have mosquito nets distributed for especially women and children to sleep under in order to prevent them from coming down with malaria, they do not. And other preventive drug-based intervention, like the seasonal malaria chemoprevention, when we deploy them, sometimes it's not optimally utilized, as it were. And also the need for persons that come down with fever to present at health facilities in order to be tested and be sure that they have this malaria. Because one of the problems we have, though like you said, is a burden, but it is not as it used to be before. Like you mentioned, that you've known malaria since when you were small, but the prevalence even from our surveys, have shown that there is a steady decline in malaria cases. Because
by how much percent? Because we would like to know. If you
yeah, for example, from in 2010, because there is what we call the malaria indicator survey that is usually conducted like every 5 years in order to see the prevalence of malaria in Nigeria, for example, and other countries that are also endemic for malaria do such surveys. In 2020, when it was done, it was 42%. And by 2015, when it was carried out, it had declined to 27%. And furthermore, when the National Demographic Health Survey was also carried out in 2018, which is almost similar to the malaria indicator survey, we had 23%. You can see the steady decline. There's a recent one that has just been conducted in 2021. It was supposed to be in 2020, but because of the COVID-19 pandemic, it wasn't carried out. It was done last year. We're waiting for the result.
Is the drop in percentage, the progress made, is it driven by demography? I mean, is it driven by what is the driving factor? Okay,
very good. So the driving factor is the interventions that are put in place in order to control the malaria infection environment. For example, like I earlier mentioned, the use of mosquito nets. Oftentimes the federal government, in collaboration with international donors and partners, often deploy interventions like mass distribution of mosquito nets to the general populace, and also provision of testing and treatment services, especially at public health facilities for free for persons with malaria. And also, more recently, we have steadily scaled up what we call the seasonal malaria chemoprevention.
You will get to that. Dr. Shakarao, let me just put you on hold and bring into that conversation pharmacist Al-Hasan Mohammed. And I'm wondering, you listened to the reduction percentages now. It's going up and up and down. At a time, we're making appreciable progress and all that. Is this driven by any behavioral attitude?
Yes, thank you very much for this opportunity. Yes, malaria response has been prevention and treatment. So the prevention aspect that included the LLN and the seasonal malaria chemoprevention, the strategic behavioral change communication has been on increase under various interventions that we are doing, like the LLN distribution that we did under Save 1 Million Lives for residents of FCT in these two political wards. We're able to mobilize women and children, and then we communicate all this information in radio, television. I think I was in this studio twice to communicate to residents of FCT on how to use appropriate preventive measures, like sleeping under LLI, pregnant women attending.
You have to keep explaining LLI.
Okay, long-lasting insect-treated nets. Then accessing preventive drugs in our facilities. Sulfadoxine pyrimethamine is a drug that we give women to prevent malaria when they are pregnant, when they reach 5 months, or when they start feeling the movement of baby. They are supposed to present into antenatal clinic for assessment. If they are eligible, they will be given preventive medicine to prevent them from falling sick. So that's the stage of being vulnerable to malaria. And then our children that are under 3, as part of scaling up the prevention method, national.
I'm asking. Sorry, you will get to all this. Okay. I don't know if it's a preamble to answering my question, but I just like to know if there are altitudes, that have impacted, behavioral altitudes that have impacted on, the efforts to eliminate malaria in our country.
Yes. The intervention has spread and reached all the nook and crannies because of means of communication now, internet services, radio, television, where there are packages of messages from time to time that media houses are giving us. So people are imbibing the spirit of using preventive measures. In fact, we have reached the whole community in FCT with communication, text messages, NTA services and radio services on how to use LLN and other preventive measures.
Yes,
they are using them.
I know what you're trying to. Dr. Shakarao, you understand what I'm saying? What my question very well.
Yes, I get your questions very well. So there are behaviors actually that affect the uptake of these interventions that are being deployed. For example, my colleague mentioned the need for women who are pregnant to patronize health facilities when they get pregnant, because at that stage they are very vulnerable to malaria, because their immunity tends to come down a little in order to accommodate the baby. And so infections like malaria can easily get into their system. And so there are interventions put in place, and most of the time for free by the government and partners. For example, the use of IPTP. But antenatal attendance, as we speak in the country, is still low. It's not optimal the way it should be. So that if women who are pregnant, especially in a rural setting, go to facilities and they take this intervention, like for malaria, for example, the use of Fansida or sulfadoxine pyrimethamine, which will help to reduce or prevent them from coming down with malaria. And also, they are usually given mosquito nets in order to prevent malaria. And also behavioral issues like not keeping the environment clean, especially keeping cans that can easily take water. And you know, mosquitoes like breeding in fresh waters, especially during rainy season. They prefer clean water. In fact, mosquitoes
really?
Yes.
Clean water?
Yeah, clean.
But that's not what we're told.
Yeah.
We're advised not to keep stagnant water, your gutters, clean your gutters. Please go ahead, Doctor.
Yes, excellent. So those are some of the, behavioral issues. People are not well known. The truth is, the environment needs to be clean at every time. But science has shown that from studies that mosquitoes prefers clean water. And the reason why they breed more during the rainy season, when water tends to there's downpour, and if there are buckets or empty cans, bottles and what have you around, so when the water settles there, they easily breed. They don't like breeding. Mosquitoes are even clean.
I'm even surprised, because if you look at them, they're quite very tiny, and I don't know how they're able to survive.
Yeah, so they breed because they readily, the fertilization readily goes on in them, the male and the female, when they mate, and the eggs are, released into the water, and then the larvae and what have you grow and then become the actual mosquito.
Because we are the medical doctor, that's why I'm staying longer. I'll still come pharmacist Al-Hasan to talk about the drugs, because most times you find that a lot of people just go to any nearby pharmacy or chemist and procure one particular, and there's so many drugs out there, malaria drugs allegedly out there. But Dr. Shakarao, is there a relationship between the unborn baby and and malaria? Is there a connection? Because most times you find that pregnant women are warned, to ensure that they don't come down with malaria.
Yes, so very good question. In that, like you have rightly mentioned, there is actually the answer to your question is yes. There is a direct relationship between an unborn baby and who is in the on the pregnancy stage. They tend to have what we call low birth weight when the malaria parasite is much in the system, because what happens is the parasite will now be competing for the nutrients with the baby in the placenta. It's the placenta that gives the nutrients that the baby takes. So when those malaria parasites are much in that placenta, they tend to, compete or take most of the nutrients. And so the baby that is supposed to have that nutrient is not getting it, and so they can come out as low birth weight. That's even if the mother is lucky to sustain that pregnancy, because malaria can also lead to abortion. Yeah, you know, miscarriage is the one the general public knows as miscarriage. So it can lead to that miscarriage, and it can even ultimately lead to you know, the death of the baby while still in the womb. And so those are some of the effects of malaria on the pregnant woman.
Pharmacist Al-Hasan Mohammed, a lot of people, you know, consume so many things, you know, of course, because of the availability of many drugs in the market, allegedly malaria drugs. Are these also in any way impeding on efforts to, you know, roll back malaria?
Yes, thank you for this question. The standard method for malaria response is to visit a facility where you can be tested first to confirm that your fever is actually caused by malaria parasite. So treatment that
what about communities where they don't have, you know, nearby facilities to go for tests? Rural communities, for instance, they feel, you know, rising temperature and all that. What can they do? How can, you know?
The test, we have a simple testing method that can be done even in a chemist shop. The rapid diagnostic test strip is excellent in dictating malaria parasite. So it is not advisable for you just to have, when you have abnormal body temperature, you say it is malaria. It may be fever from another communicable diseases. So it is testing first before treatment. So you must access that service of testing to confirm it is the malaria parasite that is causing your fever before treatment. So don't advise people to just go across counter in a pharmacy to procure, or chemist shop to procure anti-malaria and swallow and say that.
What about those who also consume local herbs?
Well,
are there herbs that have the potential of treating malaria, you know, fever?
For now, there's none yet that is approved. It is always advisable you visit health facility, get tested first to confirm that there is a parasite malaria that is causing your fever. Because the fever can be as a result of any other bacteria.
We hear a lot of people talk about, you know, doctor, and I would also like you to respond here. I mean, when they get, you know, when high temperature, raised temperature, I mean, the popular dongoyaro, I know about it, you know, and it comes in, there are also roots. They come in different colors. And you hear a lot of people, especially the, you know, the artisans, you know, the mechanic, they'll tell you, this thing treats malaria. Once I take it once, it goes. So what about those roots? What about those herbs? What about all the moringa? You know, there's so many things that people tell you that you take and it treats malaria. Are you saying they're not effective?
They are not effective because there's no scientific basis to confirm whether it is malaria. First, you have to be tested, because fever can be as a result of even physical beating can give you fever. It could be bacterial fever, it could be viral fever. So you have to avail yourself with service of testing before treatment if it is malaria. Malaria has to be confirmed that it is in your blood. Then you go for ACT, artemisinin combination therapy. These are the standard drugs that are used in treating malaria. Those have, they are not antibiotic, they are not anti-malaria.
What are the benefits of going to an established health facility to get tested for malaria?
Beautiful.
Okay.
Beautiful. This is the standard treatment. We encourage all residents of FCT to access all our primary health care facility in this is 2 political ward for testing before treatment. In fact, National Malaria has launched some program around 2002 where they even engage patent proprietary medicine vendor stores to distribute certain anti-malaria, and they refer them to testing center before giving those drugs. So the National Malaria, in collaboration with the FCT Malaria, have engaged in sensitizing even the lowest chemist facility in the community on referral system, because referral service is very important. If you cannot do, when somebody appears to you with health challenge, you refer him where he will be treated rightly. If it is malaria, it has to be tested confirmed that the parasite in his blood, then he's given the standard treatment using the malaria combination therapy. So it is very important.
Doctor, what are the benefits of getting tested for malaria?
Okay, excellent question. And one of the things that we at the national program and even state malaria programs and the Federal Ministry of Health generally were worried about, because one of the key behavioral issues that we have found is the concerns of self-medication, especially like my colleague had likely mentioned, persons when they feel hotness of the body or they feel feverish, the first thing that readily comes to mind is that this may just be malaria. And the narrative have changed over the years, like I rightly narrated to you, how the prevalence of malaria had changed over the years. And so, in fact, before now, like for example, when I was in the medical school, what we were taught was, when you see a fever, it must be malaria until proven otherwise. But things have changed because a lot of resources, a lot of interventions have been deployed, and so the prevalence or the cases of malaria over the years have really gone down, in that such that when you see fever, now the recommendation is that you have to be tested to be sure that that fever is actually malaria.
Why do you think people are willing to go for, to test for malaria?
Yes, so the truth is, like my colleague have mentioned, persons oftentimes are not aware of what to do when they get feverish. Like he has rightly mentioned, for example, in FCT, in all the wards of FCT, there are public health facilities whom are equipped with testing kits and or even free malaria drugs. But because people do not want to, take the pain or the stress of patronizing health facilities in order to, get tested, they just want to boycott and just quickly get into one chemist or the other in order to get the malaria or do self-treatment, which is totally discouraged for whatever illness, not just malaria. It's not encouraging for you to just go over the counter and buy medication. Sometimes they don't even take those medications at the dose that is supposed to be given. And like my colleague also had mentioned, we are also engaging with, or there's even a renewed effort of us to engage many of the chemists and pharmacy shops in order for them to be better sensitized that there are easier ways of testing malaria. Before 2010, the only way to test mainly is through microscopy, which is mainly done by microscopists in the hospital. But now
you have to go to the lab.
You have to go to the lab. Excellent. So now we have rapid test kits, just like we have for many other things. For example, even a woman who is suspected to be pregnant, she can easily go and buy pregnancy strip and maybe hepatitis or HIV, all those rapid test kits. Yeah. That is also available and for malaria, which is also very sensitive and reliable. When done, it will actually tell you if that fever that you have is malaria.
A very good place to take a break, Dr. Shakarao and pharmacist Al-Hasan. Thank you. When we come back, I'd like for you to also talk to us why children, under the ages of 5 are most vulnerable to malaria. This is late edition, and we're looking at specifically seasonal malaria chemo prevention. That's our focus, and that we will get to when we come back from this break.
You can't fight piracy, you can't fight a war.
Therefore, you don't claim your rights.
The challenge I see is in the fiscals.
Do we have to wait until we have a problem?
See, the problem with those who speak on behalf of themselves and the country is that they should have facts. I'm speaking now as Minister for Transport.
For you to become economically independent, you must have to curtail level of importation of other people's products and services.
How rich you are, you can't bring certain vehicle into the country.
Okay. There's no competitiveness within the state.
I am Claire Adelabu Abdulrazak. Thanks for joining me. Welcome back. This is late edition. We're looking at seasonal malaria chemoprevention, SMC, this week. And I have with me Dr. Shakarao Emmanuel, who's the National Focal Person, SMC, National Malaria Elimination Program at the Federal Ministry of Health. And also joining me in this week's conversation is Musa Al-Hasan Mohammed, who is also a pharmacist, but he sits as Director, Health and Human Services Secretariat, FCT Public Health Department here in the Federal Capital Territory. Gentlemen, thank you once again for joining me for this conversation. So, why are children most vulnerable to malaria?
Thank you very much. Children that are born maybe 0 to 3 months, they tend to have little immunity from their mothers. But a child of 3 months to 59 months is most vulnerable to malaria. Okay. A small bite, you fall feverish, you start convulsing, and so if it's not treated in time. So 3 months to 59 months, it is our duty, FCT Malaria Elimination Program, Health and Human Services Secretariat, to provide all preventive measures from conception mothers in our facility to prevent mothers from getting malaria, to prevent children that are under 5 from getting malaria. So we provide them preventive services like giving them long-lasting insecticide-treated net. And now of recent, FCT and Oyo State were added to another preventive method for this under 5, 3 months, 59 months, seasonal malaria chemoprevention. It's a drug treatment that we give during the peak month of malaria. So we...
Okay, doctor, why are children within this age bracket, most vulnerable to malaria?
So, well, the simple fact of why children in that age group is just because their immunity has not been built to a level where they can easily fight most infection. If you notice, it's not just malaria. A lot of our health interventions, are targeted towards the children under the age of 5. And the simple reason is because that mechanism put in place in the body to help fight any infection that comes into the system is not yet well developed. It's after that age of 5 when they have been, to a large extent, vaccinated or immunized, whether through natural means or through, health intervention like taking vaccines and what have you, then they are able to fight this infection. Like for adults or children above the age of 5, because of some level of repeated attacks of malaria, the body immune system is already triggered. There are some cells in the body that are produced in order to recognize that when this parasite comes into the system, it is actually like maybe malaria parasite, and they are able to fight back. And that's why for malaria, for example, you do have partial immunity in adults and older children. There's what we call partial immunity.
Is there any true validity in the belief that some people with certain blood groups and genotype, are more, have a better immunity, while others are susceptible to coming down with malaria, specifically the AA and the O+, genotype? Is there any truth in that?
Well, there's no much, enough evidence to prove to that effect. But what we generally advocate from our National Malaria Strategic Plan is all persons. So we do not segregate in that whether the person's blood group is this or and that. The general notion is that persons with AS or what have you tend to have some level of protection against malaria. But
AS?
That's the blood group,
yes,
AS.
Yes.
But that is not what the World Health Organization encourages, or even we as adopted by the National Malaria Program. What we emphasize is that all persons with fever should actually be tested, and then when they are found to be positive, they should have access to treatment.
Okay, let's talk about prevention. And I know there was a time in this country when the issue of net, anywhere you go, it is the, you are encouraged to use the long-lasting insecticide-treated nets. Everywhere you go, communities, pregnant women, and all that. What happened? Suddenly, nobody is using the mosquito nets. Maybe I shouldn't say nobody. Very few people use it these days. Pharmacist?
Yes. Thank you very much. I think it's the we should re-inform our residents on that the use of LLN is still valid means of prevention of malaria. So it's up to us now to take up the strategic behavioral change communication to all nook and cranny. We've just distributed them recently for every resident of FCT. In fact, we are about to secure some support where we'll do mass campaign, courtesy of National Malaria, who mobilize funding for us. We may be having the World Bank support on that impact project. We just finished the Saving 1 Million Lives, which just targeted children, certain group of children that we distributed LLN with pregnant women. But the use of prevention using LLN is still a valid method of prevention.
What about those who complain about the chemicals used in preserving it? I don't know. Are you dismissing that?
Yes. No. You see, this LLN, unlike the ITN, there's ITN which you have gone beyond that. This long-lasting insecticide has a standard method of handling.
What's the difference? Is this?
This is the long-lasting insecticide-treated net. This one, the chemical is embedded in it. When we are giving communities, we ask them to open it and spread it for 24 hours in a shade so that the chemical will...
Is it possible to see what's inside?
Yes. This is a sample of long-lasting insecticide treatment.
What about those that they sell, along the roads and they come in different colors?
They're still I'm sure
are they still effective?
Yes.
They hawk?
they are effective. I'm sure they are satisfied to be sold in the Nigerian market before they start selling them. So these are the ones we use. You spread, if we give you, we'll ask you, that's why we normally give them open so that they can do other things other than what we ask them to do. Because some of them, because of the situation in the country, they can resell it or use it in their farms. So when we give you, we'll advise you to open it and spread it in a shade.
Okay, so the first step is to do what? Once you open this?
So you spread it in a shade for 24 hours.
That's 2 days?
Yes, 24 hours so that the chemical will reduce. So,
well, sorry, approximately 24 hours is one full day?
1 full day.
One
in a
full
shade,
day.
not in the sun.
In the shade?
Yes.
Not in the sun?
Yes, for 24 hours.
In the shade, not in the sun. In the shade, not in the sun.
Yes.
Okay, and then what next?
The next thing is that we'll teach you how to handle it, how you talk.
Who does the teaching?
The people that, when we distribute, we normally train people who distribute this net to communities. So they will train the women and beneficiaries on how to handle this, how to wash it, how to tuck it into your bed, when to go and use it when you want to sleep, how you sleep on it, and your baby. So we have a package when we give net. Like the package is the kind of soap you use in washing it. If you use it correctly, you are not going to use caustic soap. You use mild soap like this. The old Lux soap and Joy soap, these are milder than this modern caustic soap. Then it will last for 3 years if you are able to handle it well.
Yes.
Yes. If we give you like this one now, you are able to wash it with mild soap. You spread it. It will last for 3 years before it expires.
How many people is this likely to protect? How many people can go under this?
Okay, two persons.
2 persons.
A husband and wife or mother and a baby can sleep on this.
Okay, so to get all-round protection, you need more of this, assuming you have a family of 4.
Yes, family of 4. Well, yes.
Is this given free?
Yes, we give free to 1 per household. So if you have more, we'll give you more. But because of under Save 1 Million Lives, we are the North Central champions. So out of our earnings in FCD, we procure this. We restrict it to under 5 and pregnant mothers, because we don't have enough for mass campaign. But I have said the National Malaria has just mobilized funding for us under 12+1. We are going to be part of the impact project where we do mass campaign.
Dr. Shakarao,
Yes.
so we've talked about this. This is still very effective.
Yes.
Absolutely.
It's still very effective.
It's very effective.
Okay.
It's a key intervention that has been recommended by the World Health Organization, and that is being used by a lot of malaria endemic countries in order to, tackle and even eliminate malaria in the countries. There are newer African countries that were endemic to malaria that had just eliminated malaria from the countries. And these are some of these interventions that we deploy are based on global best practices. And one of those key preventive interventions is the use of insecticide-treated nets, which it can be used. And for universal coverage, what we advocate is, like you mentioned, 2 persons to 1 net. Yeah.
Okay, so fine. This we know. SMC we don't know. That's seasonal malaria chemoprevention. I'm hearing it for the first time.
Seasonal malaria chemoprevention was first recommended in 2012 by the World Health Organization. And when World Health Organization recommends interventions for countries, Nigeria as a country, you have to carry out some sort of feasibility studies in the country, which is in form of a pilot. So following the recommendation in 2012, the Nigeria National Malaria Elimination Program, Federal Ministry of Health, with support from partners, piloted the intervention in Katsina State, in few local government areas, where it was really found to be, effective, acceptable, and, feasible to deploy. So after which, by 2014, Nigeria National Malaria Program adopted it as one of its key strategies, and we now included it into our National Malaria Strategic Plan 2014 to 2020, and also we reviewed our national guidelines for diagnosis and treatment of malaria to include this intervention as one of our key interventions. So since then, steadily there has been scale up, with availability of more fundings. For example, Sokoto and Zamfara State has been implementing this intervention at full scale.
At school?
At full scale.
Full scale?
Full scale since 2015.
And it's strictly for under 5?
Yes, strictly for under 5.
That's children
aged between 3 months to 59 months. Just before entry into 5 years, persons are no longer eligible. And then persons that are less than 3 months are also not eligible. So it's the ages of 3 months to 59 months. And so with the scale up, there has been steady increase. And when it was first recommended, it was just in 9 states of the country. That's those states that are in the Sahelian belt. For example, Kebbi, Sokoto, Zamfara, Katsina, Kano, Yobe, Borno states, Bauchi state. Now, the reason is, like you have read, like even from the name, seasonal. And I recall from your introduction, you talked about when rainfall tends to be more. Peak. So, and it peaks more actually from the month of June up until October. Yeah, so that period is when it's targeted for this intervention, because that's when mosquitoes breed more, and then transmission tends to also be more. And so you target that period in order to bring down the transmission or truncate the transmission, especially among children under 5. So it will bring down cases and also even the severity occasion for malaria. So that's why the intervention, and it's a chemoprevention. The reason why you can't deploy it all through the year, you don't want to deploy medicines, for somebody, and it's usually taken at monthly interval for 4 months. The medicines are usually for during that rainy season, and it's a monthly interval thing. So you target that month of highest peak and transmission in order to deploy this intervention.
Yes, and pharmacists, you want to explain this to us, because I'm a bit confused. Monthly interval, it's a chemoprevention, and is it receptive to this vulnerable group of children in terms of taste? Because I know a lot of children, when they see the color of some of these malaria drugs, it's even as an adult, I get goose pimples when I see them.
Yeah, thank you very much. The formulation is formulated with some flavor to be acceptable.
Can the camera pick it?
This is the seasonal malaria chemoprevention medicine that we give. This one is for 3 months to 11 months. This is the medicine. They have swallowed this, other two. This is for 11 months and above to 59 months. This is the medicine. So the medicine is in 2 colors. There is this one is sulfadoxine parametamine. So when we go to field, we started on 30th June for 4 days, 30th in FCT. This is our first time. So on 30th June, we recruited people from community. There are a team of 3 people going around the community. One is a town crier from the community in FCT here, in the 62 political ward. So they will go around to announce to the community that these services are coming, prevention for children 3 months to 59 months, that they should cooperate with service providers. Then there is the CDD, we call them, the people that administer the drug. They carry the medicine and give the mother. They inform the mother how to give. In their presence, they do direct observatory treatment. They will give the mother to give this white one and this yellow one, day 1. The baby will swallow in the presence of the health worker. They will swallow this and this. Then they will instruct the mother how to give the next day the subsequent dose. So that's how we administer this drug in the community. So
why is the southern states, are they part of, the wider, are they part of this exercise now?
No, for now,
Yes.
our rain pattern, they discovered that Oyo has a rain pattern similar to the northern state. So is this the peak period of June to October? Before we started, the National Meteorological Service has to give us go ahead.
Okay.
That rain will start this period. So that's why we started from 30th June to 3rd June, 4 days. So we're going to end it this October. It is free to our children to prevent them from having malaria during this high peak of rainy season in FCT. So
are we likely to mainstream it? It's already part of our public health services.
Definitely, we have entered into agreement with Malaria Consortium to run it from this 2022 to 2024, to 2022 to 2024. So they are supporting us to offer these services to our under 5 children in FCT.
So, Dr. Shakarao, what are we doing to upscale it, to more states across the country?
So, yes. So, like I was saying earlier, it used to be only 9 states that were eligible. But with the review of our National Malaria Strategic Plan and certain contexts being considered, what we call stratification, it was found that before now, it's mainly the northwest and the northeastern states that have shorter rainfall. But with more analysis, it was found that all the states in the north central, as well as a very minute part of Oyo State, about 6 local government areas of Oyo State, are seen to have similar climatic condition with the north central as well as the northwest. And even for the north centrals, mainly their cycle, that's the number of months they deploy it, it's about 5 months, while those Sahelian states that are at the top of the Nigerian map then tend to do it in 4 states. So we have scaled up to 21 states now, from 9 states to 21 states. And in some of those states, it's not all the local government areas that are eligible. So for the southern states, they are not eligible for this intervention. There is a sister intervention that they were planning to deploy in those.
Okay, the southern states are not eligible for the SMC.
For SMC, they are not eligible.
That's interesting. So, is it a one-off thing, or is it periodic? How often do you need to take the SMC drug?
Yes, so in a year, it's for about 4 to 5 months. The children that are eligible, among the eligible children, is for 4 to 5 months. And it's yearly. Every year, there is no delay until we are able to actually eliminate malaria. It's now captured as one of our key strategies for control of malaria.
Is it a one-off thing for a child, a particular child, or do you need to, you know?
So that child, one child will take it every month for the 4 to 5 months.
For 4 to 5 months, and that provides the required protection.
Yeah, it will provide him with.
So you don't need to take again in the next round.
No.
What about the vaccine that was, you know, introduced by the WHO?
Excellent.
It was also meant to prevent, provide protection against malaria.
Yeah, yes. So like you even mentioned concerning seasonal malaria chemoprevention, seasonal malaria chemoprevention, for example, alone cannot provide the 100% protection for the child. It has to go with other interventions like the use of insecticide-treated nets, and you know, the need to promptly present at health facilities if they have fever to be treated for those of them that might have already caught malaria. So for the vaccine, it was recommended by the World Health Organization in 2021, October 2021. So as we speak now, the accessibility and availability of this vaccine is not yet at scale. It's not even for countries that piloted it. It was 3 countries that piloted the use of this Mosquirix, that's the malaria vaccine. That's Ghana, Malawi, and Kenya.
Yes.
Yeah. So even those countries, there are talks ongoing by National Malaria Elimination Program, and you know, the vaccine is usually the responsibility of the National Primary Healthcare Development Agency, and there are international organizations that also support the deployment and availability.
So it's not here yet.
It's not here.
It's not available in the country yet.
Yes.
Okay. Just a final words from Al-Hasan. Right now, you know, residents of the FCT should expect your men with these SMC drugs, and it's to be given free of charge to children under 5 years. Is that what it is? Can you quickly give us a recap of what?
Thank you very much for this opportunity. We are calling on all residents of FCT in this political world, mothers with 3 months, with 9 months, to avail themselves. We are having a team of drug administrator, town crier, and lead mother will go around house to house to administer this drug to your children free of charge. Please cooperate with them to ensure you access this. Even if you are living in Maitama Asokoro, there is no SMC in Dubai or UK or US. We are the expert in SMC. So please allow them access to your children. That there's SMC activity going on. We started in June. We are going to end it in October.
Okay. All right. That's Musa Al-Hasan. Yes, quickly.
Yes. In addition to the FCT, the whole 21 states of the country that are eligible for SMC in Nigeria, we're currently deploying this intervention. And because NTA, it's a widely broadcasted media station, and I'm sure a lot of populace are watching us all over the country and even all over the world. Those 21 states ensure that when you see every month during the rainy season when these drugs are being distributed, please make your children available for this intervention, because it helps to really bring and protect them from having this malaria infection. And it has been found to be really acceptable and very effective in preventing malaria. Thank you.
Dr. Shakarao Emmanuel, National Focal Person, SMC, National Malaria Elimination Program, Federal Ministry of Health. Musa Al-Hasan Mohammed, Director, Health and Human Services Secretariat, FCT Public Health Department. I'd like to appreciate both of you for coming to share this initiative with us.
Thank you so much for the opportunity.
As I say, prevention is better than cure. Avail yourself of whatever opportunity that the government brings to your doorsteps, especially if it is free of charge. I am Claire Delabo Abdul Razak. From me and my production crew, I thank you for watching. Bye-bye.